with bioelectrical impedance analysis technique. And what are the precautionary steps? What are certain precautions one need to take while doing a BCA? And certain summary pointers. So understanding the need of BCA in ICU. So malnourishment is commonly seen. So currently we are using SGA scores or MIS scoring or Nutric scoring. There are lots of scales which are available which tells us about the people's whether they are malnourished, whether they are undernourished or overnourished. But it's very essential to understand their simultaneous muscle loss or probably fat loss also in certain patients over the period of time where they are having a stay in ICU. But such kind of nutritional scoring scales has a limitation that we cannot do that. So why do we need body composition? So when I talk about BCA, when I take a BMI, which is commonly done, and then I correlate it with the body fat mass done with the CT scan. So BMI is telling us the person is in the normal range. The person is not overweight or person is proper. But when I see the person, so for example, this person, first person is with the lower BMI, that is 17 kg per meter square. So this person versus this person versus this person. So muscle mass is same, but the only difference is the body fat mass. But by looking at the person, it's very difficult to understand whether the person is having alopecia or how the things are going for this individual. So therefore, understanding it in the niche level is very essential. So we will be doing this particular body composition with the help of BIA technology, that is bioelectrical impedance analysis. Out there, what happens exactly in BIA? It's firstly inexpensive. There is no exposure to the radiation and can be done with the patients on the bedside like this. And there are various parameters which we get on how we interpret it and how we see that patient that will make a major difference. So let's understand BIA technology in a nutshell.
The human body is composed of 4 main components: water, fat, protein, and minerals. Having a moderate amount of each component is important for a healthy life, and the BIA is considered as one of the most practical methods to know. BIA, bioelectrical impedance analysis. This method applies small currents throughout the body and measures the voltage to get a value called resistance, also known as impedance. The principle behind BIA is to flow electrical currents throughout the water in the body and to measure the amount of resistance the current encounters as it travels. Simply, more water will lead to lower impedance. For example, although the 2 men weigh the same, A has a higher amount of muscle mass than B. Since muscle cells hold more water than fat cells, electrical currents can more easily flow through A and will show a relatively smaller impedance value than B. And with this impedance data, the volume of a person's total body water is determined. So then, how did this technology come about? In 1969, an experiment was carried out to find the correlation between whole body impedance and volume of total body water. This study proved that the impedance index, height squared divided by impedance, had the highest correlation with total body water. This index is considered as the starting foundation of BIA devices. 10 years later, an American company commercialized the first impedance meter. This meter used a single frequency of 50 kilohertz and measured the body's impedance. Due to its simplicity and convenience, this BIA device sought attention from many researchers. However, as more researchers started using the device, they soon became skeptical of its accuracy. The device's claim to produce whole body results actually only tested the right half, and their use of a single low frequency inaccurately measured the whole body impedance. In order to compensate for its inaccuracy, scientists developed equations using empirical estimations such as age and gender. However, the equations were only specific to their test groups, and with so many additional factors to account for, no equations were applicable to all. After years of developing additional equations and incorporating empirical estimations, scholars concluded that technological improvements, rather than equations and estimations, were required to overcome its inaccuracy. BIA required technology that can provide segmental impedance and body water compartment measurements using a multi-frequency method. Then in 1996, the InBody, a body composition analyzer that took into account the limitations of conventional BIA devices, was introduced. This technology included segmental measurement, use of multi-frequency analysis, and an 8-point electrode system. With these advancements and without the use of empirical estimations, the InBody achieved 98% correlation with DEXA and an impressive reproducibility of 99%.
So understanding the bit of a BIA technology was necessary. So now understanding the result sheet will play a major role. But when we see the result sheet, there are so many parameters on the result sheet. For example, look, we have the body composition history, we have muscle fat analysis, we have obesity, segmental analysis, extracellular water ratio, and so on. But how do we interpret so we can get a proper analysis of the individual? So assessing the sarcopenia of the individual, we all know what sarcopenia is leading to, and it has got an increased risk of mortality. And assessing sarcopenia is very essential as it is commonly seen in the patients who are acutely ill and in ICU setup. So it's very essential to assess that. And how do we assess it? With the help of BIA, we have skeletal muscle index. So we need to divide appendicular lean mass by height in meter square. That is your right arm plus left arm, right leg plus left leg, and height in meter square. So for males, it should be 7 kg per meter square, and for females, 5.7 kg per meter square, as for the Asian population. Understanding the severity of the patient by the phase angle. So what is this phase angle? Phase angle is nothing but it tells us about the mitochondrial health, cellular health. So the better the cell is, better the phase angle is. If the cell is damaged or if the person is having too much of water retention, then the phase angle is on the lower side. But that water retention can be because of intracellular water breakdown and extracellular water increase. So therefore, it's very essential to figure out what is the phase angle of the individual. And researchers say that it is very crucial marker to understand the prognosis of this patient. So this is how the phase angle is. So we pass a small impedance through the cell. It will replicate somewhere. So now where it will replicate and intersect it with each other, that angle is known as phase angle. So if the cell is intact, the angle is more. But if the cell is damaged, the angle is less. So how do we interpret it? Anything between 4 to 6% or anything above 4% is good. Aging or probably because of chronic ailment, it is between 2 degree to 4 degree. Anything below 2, it's very critical. And what does researchers say? It becomes very crucial marker in order to understand the severity of the individuals. It can help us to know the mortality rate of the individuals in ICU. Also, there was a study wherein they were assessing phase angle along with various scales, and they figured out BIA turned out to be a reliable tool for assessing and understanding the mortality of the individuals based on their phase angle. This is one more research talking about the same, wherein they actually figured out with the help of phase angle about the mortality, and they also checked the nutritional score for the same. Now, this is a small case study. There was 145 centimeter person with 45 kg of weight. She was 82-year-old woman. She was admitted in digestive internal medicine. She was having a carcinoma. There was a severe edema which was observed in her. So her overall face angle was 3%. But there was an improvement. Initially, it was on a lower side. Slowly, there was an improvement which was seen. It was an inpatient. But later, the face angle dropped down. In this person, who is again 77-year-old woman who had a trauma, the person had the abdominal surgery. But when we see the phase angle is dropping down, it was less than 2. The person passed away because of sepsis. If we can see this report, the water levels were going really on a higher side. Weight was dropping. Her intracellular water was dropping, but extracellular water ratio was increasing. So when intracellular water drops down, that is a classic indicator there is a muscle breakdown or there is a cachexia taking place in certain individuals. Now, how do we understand why I am focusing more on the water levels? So, fluid retention is commonly seen in the person who has a higher risk of mortality. So now we have this intracellular water versus extracellular water. So intracellular water is always at 3 and extracellular water is always at 2. So if we see that ratio, that healthy ratio is between 0.360 to 0.390. If we see the chart here, this graph, it should be in one straight line. But we see the disruptions here. And when we see this, this is slightly over and this is in the over category. That is a classic indicator this person is having fluid retention. Now to understand that fluid retention is because of any kind of chronic ailment or because of muscle breakdown, it becomes very crucial. So that's why I have a small case out here. This is your normal cell where intracellular water is 3 and extracellular water is 2. But in the case 1, here intracellular water is 3, which is a good sign. But extracellular water has increased. So that can be because of any kind of chronic ailment. That can be because of acute heart failure or chronic kidney disease, post-trauma, or any kind of inflammation which has taken place. We see rise in extracellular water. But now the cell sizes remain same, but intracellular water has dropped down. That means there is a muscle breakdown taking place. So that can be because of malnutrition taking in coming in the picture. There is an aging process. There is cachexia. The person is going towards sarcopenia. So that can be understand very clearly when we assess the water levels. So is there intracellular water dropping down or there extracellular water is dropping down? So most of the times we see certain cases in our ICU wherein we see the patient is into severe edema and we try to maintain the dry weight. But maintaining the dry weight, especially in the renal patients, it becomes very difficult because we are just looking at the fluid balance. But when we step up and step ahead and see whether they are breaking down their intracellular water, then just removing that water through the dialysis is not going to help entirely, but going aggressive on protein and slight amount of physiotherapeutic exercises and their behavior modification will help them to retain their muscle mass and thereby retain their dry weight also. So that becomes very easier just by understanding what will be our line of treatment when we figure out what is the difference in their edema. Is it because of the existing disorder or because of the muscle breakdown? This is a screening of DVT by this extracellular water. So we all know what is DVT. So I'll just skip through. So this was this 55-year-old patient. So patient was admitted in the ICU. So overall the water level was high, but only out here it was on a higher side. So here at times it becomes difficult to figure out whether the person is having DVT in which limb. But this was a classic symptom where only one limb was having higher amount of extracellular water as compared to other. So that was a actual alarm to understand whether the person is having some kind of DVT in their leg or any issues, why the water level is high only in one limb. So it's very essential that all water levels should be in one straight line. The disruptions or variations of 0.007 can lead us, can give us the brief overview about those individuals out here. So this person was 63-year-old man, 68 kg. There was no appearance of swelling which was present. But however, it was always coming low. But after certain period, it was still the same. That's why they did this ultrasound. And they figured out there was a thrombosis and then the clot was removed. Because only at one leg, the ECW ratio was on a higher side. So we can also do certain kind of interventions provided we monitor the patients based on their limb also, segmentally. And how do we figure that out? If the extracellular water ratio, as I mentioned prior, 0.360 to 0.390, if it is on a higher side, then that can be because of the organ dysfunctioning. But if we see only at one side, with the difference of 0.007, then there are higher risks that person is having musculoskeletal injury or edema. It can be acute injury also. If the both the sides are having higher edema, it can be idiopathic edema also at times, or it can be because of lack of muscles or paralysis. So when I say lack of muscles, it is because there is an edema when intracellular water is on the lower side. So because there is a edema in the legs. Most of the times you will see the patients may have edema in the leg, but that won't be like physically appearing to us. But there is a edema. So that is not because they have got any kind of ailment out there, but because they have got lower muscle mass in their legs. So therefore we can see edema in those individuals. Then combination of lean and extracellular water. This becomes very interesting in order to assess the patients, as well as very same time it helps us to give the broader spectrum for the individuals. So now today when I'm assessing the patient, it's a follow-up case. So I see my patient is dropping the muscles and increasing the extracellular water. So 1 minute. I'll just quickly go back to the slide. I'll show out here. So in this, when I meant, what I meant was, out here in the body composition history, we have got weight, we have got skeletal muscle mass, percentage body fat, and extracellular water ratio. So out here the history has been tracked. So in this history, if the muscle mass is dropping and the extracellular water is increasing, that indicates the muscle quality is dropping, which is not a good sign. So out here, the fluid restrictions is very essential. Sorry, the sodium restriction is very essential, and certain guidelines wherein they can reduce the edema in this individual. Out here, when the muscle mass increase and extracellular water decrease, that means the muscle mass is increasing. But on the contrary, if the muscle is also dropping and extracellular water is also dropping. So most of the times, if we just assess muscle along with fat, it is a bad sign. But when I am seeing it with the water levels, it's a good sign because the person is coming out of excessive water retention. So it's very proper that the muscles are also coming down, means the inflammation is coming down. Then there is a condition where the muscles are going up, extracellular water is also going up. So that indicates that there is an increase in the edema which is seen in this patient. So it's very essential that we work up and we see to it the person is not going into inflammation. Accordingly, the management can be planned for this individual. So it's very essential to monitor muscles, not in the basis with fat, but with the water levels in order to understand the quality of the muscles, inflammation. And there are certain precautionary steps. One, there is biggest contraindication. One, with the pacemaker are advised not to do the test. When we are doing the test, it's ideally advised not to feed just before the measurements, because at times when you feed the individuals, So what happens is muscle mass is extra overestimated. So it's very much advised that we do it in the phase of 1 to 2 hours fasting. Most of the times the test is done post physiotherapy exercises. So it's very essential we avoid that, because during the workouts or during the physiotherapeutic actions, there are slight amount of muscle pumping. So that can lead to excessive muscles. So as it works on the water level, so since there is a change in fluids, so the muscle will be overestimated. It should be performed post excretion of urine, but at times it is not possible in ICU setup, so we can skip this pointers. Measurement is ideal to be done in the morning, but if the person is in the ICU, it can be done as per the timings which can be fixed with the doctors. It should be done on normal body temperature, because if someone is having fever, that time the composition will change. It is very essential to maintain that posture in 10 to 15 minutes. Since we are doing it in critical care, the people will be in supine posture only. Measuring on the wet bed may affect the results. So see to it, it is on a dry and it is not coming in contact with any kind of metals. So in case if they are lying on the bed, so the towels or the bed sheet can be put there in order to avoid the current hindrance. So to sum it up, in order to understand the severity of the patient, we can check with the phase angle, water balance, which will tell us about the mortality, complications, and recovery. ECW ratio, extracellular water ratio, is very essential to be monitored. Along with that, I would like to add segmental lean mass will play a major role out here. Screening for DVT is purely segmental extracellular water. And for nutritional assessment, we have got entire result sheet. Apart from that, we also get the visceral fat levels in the device, and we also get bone mineral content with the help of BI technology. So that helps us to assess the individual in the proper way and give them a proper line of treatment.
Thank you, Dr. Ankita.
Thank you, Ankita. It was a very nice presentation, and you touched upon very important areas and very core areas which are of immense interest for the intensivist, particularly with regard to the changing. Now, since you know that in a patient who is in the ICU, the dynamics change very fast. And the kind of measurements you mentioned, on the basis of such measurements, if we initiate some treatment, that might show results within hours or minutes. So if a patient is, how frequently, what should be the frequency of measurement of BIA to see, and where it will, and how to see those parameters, like you said, phase angle, you said the ECW. So when we try to see the response to treatment, suppose patient is, maybe we are squeezing out water with diuretics or doing dialysis. So which of those parameters is important at which stage? Early stage, late stage, like that?
So once we start assessing the patient in ICU setup, we advise to do it on a daily basis, because that's very much essential as dynamics change daily. So the water level and everything, we get it on the result sheet. As you asked me, we will get it on the result sheet immediately. So as I said, it's a non-invasive test. We just get it in 60 seconds, 60 to 120 seconds, we get the sheet. So once the sheet is with us, we can compare the prior day and the current day, and we can correlate what are the changes and how aggressive we can go, or we need to take a call on certain things. So that is how we do it usually.
Actually, bioimpedance has been used extensively in dialysis unit. It has been they are using for a long time. Like, not that all they give all this data, but simple bioimpedance monitor just to tell about the body water. It has been, I have also experience of using this, and like how much ultraviolet to given and how much diuresis to be given. We can just adjust with that.
Sorry?
Yes, I have a just query. Doctor, I think Dr. Animan can tell you. Since this is
Sir,
this
your voice was cracking.
okay, since this equipment can tell us about our fat, about our water content, can we modify our drugs according to that? Like whether we should increase the dose of fat soluble medicine, or whether we should decrease or increase or decrease the water soluble drugs. Like, can we use the equipment to modify our medicine and antibiotics and all?
So that has been done. So talking about the dialysis, so in Japan, we have we are present in almost all dialysis centers. So they are using it for doing the same thing, wherein they modified their medical treatment as well as this nutrition treatment. For dialysis patient, it is usually done post dialysis in order to understand whether there is the still scope to remove certain fluid or they have removed excessive water. So that way, to understand the dry weight of that individual, they are using that, but it is done post dialysis, not pre dialysis, because the patient is into severe hydration. That's why the fluid status is very much volatile at that moment
I didn't
before.
get why it is only post that is not pre-dialysis.
So
Can you-
pre-dialysis, what happens is the person is into fluid overload. So
Hmm.
as I said, it works on the BIA technology and water being
Hmm.
the major component. So we
Hmm.
will see the patient will be having excessive fluid retention. So the
Okay.
phase angle and everything, if we see pre-dialysis, will be
Hmm.
affected. So post-dialysis, if we see, you will see the drastic change in that phase angle. So I
Hmm.
had a case rather wherein I did the test pre-dialysis. So the
Hmm.
phase angle for all for arms was somewhere around 3.2. Stomach was the trunk area was somewhere around 1.8. Lower limbs, that was leg, was 1.8 and 1.7. So this was the phase angle which was seen pre-dialysis, and fluid status was into 0.402. That was her ECW ratio. But
Hmm.
post dialysis, her phase angle was 4.6, which was initially 2.3, went up to 4.6 post dialysis. So that was the time where BIA could work very properly. So overhydration is one of the limitation for the BIA. So once I did the test, and when I did it post dialysis, so we could figure out there was still scope of removing 200 ml from the dialysis in order to maintain her dry weight, and that became a tool for them later on.
Thank you.
I
I
think
have
Uh,
a
very
question,
important.
Ankita.
okay.
Yeah,
Yes.
please.
So, Ankita, I have a question. Like, it will be done for all admitted patients, and every patient will either be dehydrated or overhydrated.
Yes.
So, will the result vary, or there are different acceptable range for dehydrated patients and overhydrated patients?
So as I said, ECW ratio, if the ECW ratio is below 0.360 in the
Yeah.
patient dehydration patients, we will see the ECW ratio is on a lower side.
Yeah.
But for the overhydrated patients, we will see it on the higher side.
Okay.
So we
This
will
will.
figure it out with the help of ECW ratio. And it can be used not only in the ICU setup, but it can be used in OPD basis also.
Yeah.
So
Yeah.
as I said, it can be done for the amputee patients also, because we can do it in the supine posture. We can do it for the person who's sitting on the wheelchair, for someone who is into supine posture, for someone who is amputed. But for amputed, we cannot do it for assessment or screening purpose, but for the monitoring purpose. Because it will be overestimated. VIA will be overestimated for the limb which has been underwent the amputation. So it becomes a monitoring tool. It can be also done in the standing posture if we are using it on the OPD basis.
What about other physiological condition? Are there any other physiological condition it when it is contraindicated, like pregnancy?
Pregnancy, it is safe to be done. In fact, in Pune, BJ Medical College, they have one particular device where they are doing it for the pregnant ladies. But the only drawback is when there is a fetal growth, what we can see is the fat content is going high and the water levels is going high. So it cannot be used for monitoring nor for the assessment. So that becomes a drawback. We don't get a proper results as the fetus is in the growing stage. So there is no constant thing which is seen in pregnancy. It is safe, but provided you cannot even monitor neither assess. So that becomes a drawback with BIA. During menses, it is advised to avoid it, not because it will harm the individual, but because of hormones. You will see there is a graph fluctuating, constant fluctuation which is being seen. So it's very essential to figure that out. So it is ideally advised to do it post menses. However, if you want to just do it during that phase, that is also fine. But the results won't be that accurate. There will be variations of somewhere around 3 to 4% in the individual.
So I think it is very important to know this variation so that we accept what is based upon what is normalcy. Tell me, Ankita, when we know that extracellular water is how much and intracellular water is how much. Now, out of that extracellular water, how much is intravascular and how much is extravascular? Which parameters will indicate that?
Sir, actually, it will just tell us about the fluid status, not the vascularity. Vascularity.
No,
will
I'm
be-
talking about how much of that fluid is inside the vascular that is inside the vessels and how much it is outside the
So
vessels.
we give the separate ratio of intracellular and extracellular. It is written on the sheet only. Intracellular water and extracellular water. However, if the patient is into fluid overload and we want to come to know what is the exact amount the person is having, so we can also muscles, we can also check for body cell mass, which is nothing but the protein and intracellular water, which is mentioned in the result sheet itself.
Yeah, that is important for us. Like a lot
Yes.
of our septic patients, they will have lot of extracellular water.
Yes.
But out that extracellular water will be because water is in the extravascular compartment,
Yes,
in the
sir.
third space outside, and actually in the vascular three may be empty, patient may be hypovolemic. So that information has to be very important. Are there any other questions?
I think the way we prescribe our medicine only based on weight, it is very primitive way to prescribe. I think using body composition monitor to exactly know how much is fat and how much is water, and how to adjust, how to prescribe medicine will be in the future. Dr. Bisman is there. Any comment from Dr. Bisman?
Any others can also ask.
Yeah.
There are other attendees. So anybody can unmute yourself and ask any queries or any comments if you like to make or enlighten on some things which has not been covered.
Ankita, the machine you saw, the monitor you saw in that Mumbai, that is like people has to stand, but most of our RCP cannot stand. Like, is there anything, any
No,
machine
sir,
for
the
our?
machine which we saw in Mumbai, I specifically switched on the mode where we can do it in the standing posture. Otherwise,
Okay.
initially we had decided we will make the people lie down. There was a
Yeah.
table kept in between, but it wasn't convenient for everyone to lie down.
Yes.
So I
Okay.
started doing in the standing posture,
Oh,
or else we can do it in lying posture. In
okay.
fact, we don't also need to spend extra for the electrodes because they are the reusable electrodes.
Yes.
Same can be used for every patient. So
Mm,
that again cut down the income also, cost also for the
yes.
device. At the very same time, it can be used in all the three, as I said, standing posture, seated posture, and supine posture. So it becomes easy.
Dr. Sanjit here. Hi, good afternoon.
Hi,
Right.
sir.
Right.
How are you doing?
Yeah, hi. So nice talk. So I do have some amount of experience when it comes to BI. Okay, but I understand it's simple, it's non-invasive, it's rapid, it's portable, it's reproducible. Everything is there, convenient method. But it's really not sufficiently accurate for clinical use in critically ill patients. That is very clear because the way that you actually follow total body water is usually by isotope dilution, that is labeled deuterium. Okay, that is how you actually follow total
Yes.
body water, or you can do a densitometry. These are two ways you can actually figure out what is your total body water. So when Dr. Saurabh was asking that question about what happens to the fluid balance and what happens is, see, the accuracy of the BI is somewhere around 1 to 2 liters. It's not in mls. The accuracy is somewhere around 1 to 2 liters in the best possible machines. So in that case, as Dr. Saurabh said, can I do my drug management based on that? No, I don't think it's real time ready for that. However, say you have a patient renal failure and the patient has come in with and you have undergone a dialysis procedure and you want to figure out whether he is still overhydrated, maybe it's a good tool to do at that particular moment. But otherwise, I don't think we can do micromanagement of critical care by looking at this. However, as she put it, the ECW FFM ratio, this is something that you can look at to figure out whether your cumulative fluid balance is high or not. So sometimes what happens is cumulative fluid, it's so simple. Cumulative fluid balance is something that we can actually figure out by just doing every day's input minus every day's output for the last 7 days. So that same thing can be done in a number. That's what it basically says. We all know that normal ECWP by ICW is ratio is less than 1. We know that. But those patients who are critically ill patients, especially those with severe sepsis, they are prone to develop changes in body fluid distribution. And that's why, it's not a great tool when you look at just fluid management critically ill patients. Raw impedance data that you have, that is that where you're looking at phase angle, fantastic tools, because that really gives you severity. In fact, we have a study that actually says that the phase angle would actually help you to understand the mortality, length of stay much better than even the Apache scores. I think real time, if you ask me, PIA, I don't think we are ready for real time, because all my estimates with respect to body fluid assessment, which includes extravascular lung water index monitoring, it's had a problem. So every time there is overhydration, understand this, every time there is overhydration, this is a BI will provide a very poor measure of total body water every time. That means ascites, anasarca, peripheral edema, pleural effusion, overhydrated patient. All of these conditions, it will be a very poor measure of total body water, because water is actually a villain when it comes to BIA. So if you ask me, in a patient who is overhydrated, no, it's not something we would use per se. If a patient is underhydrated, yes. If a patient is coming to OPD, yes, we can actually look at that. And of course, a patient when is getting discharged, that is a time we'd probably look at such kind of data, BI. That's what I feel. It can give you objective measure up to 1 to 2 liters, calculating overhydration. This is what it is.
So as sir correctly said, it's correct. Like as I said, I also mentioned that overhydration is a problem. So that's where we look at the body cell mass of the individual, which will just tell us about the muscle point of view of the individuals. Because overhydration is one of the major drawback of the BIA.
Yeah.
So like in critical care, we say hypervolemia and fluid overload are not identical. In fluid overload can occur despite the body muscle mass being poor and everything. But hypervolemia means when everything is increasing. So likewise, in this as a fallout, I think BIA will have important role where we have to monitor the fluid management, administration, dialysis, or etc., etc. But in conditions like ascites due to cirrhosis or all such cases, probably if we cannot use BIA as a guide.
For ascites patient, or probably in that scenario, we can use phase angle, because that
Phase.
becomes a reliable tool, not only for water, but we can use it for the phase
Muscle.
angle muscle, and also for the visceral fat area, also for the bone mineral content. So it is useful with other parameters, not with one particular. So that is one thing with the BI.
Which frequency we use, MF or your single frequency, multiple frequency, or SIBIS, which is better?
So we are using SMF-BIA, that is multi-frequency direct segmental DSM SMF-BIA, that is direct segmental multi-frequency bioelectrical impedance analysis technology.
In fact, the SPEN guidelines would actually use, as clearly mentioned, that we should use multi-frequency. We can't really use any other. It has to be multi-frequency in the event of using it in the ICU, or for that matter, to make it as accurate as DEXA or densitometry. We actually need to use multi-frequency. We can't use any other frequency. Yeah.
Okay.
Yes.
Very nice. Any
Very
other
good.
questions?
Any more question?
So, you know what? I am in the middle of a study, finished a study of around 80 odd patients. And I think you guys might have seen the critical care 2023 best paper. That best paper was actually from Raheja, which actually looked at BIA and phase angle. It was a fantastic paper where we actually tried to figure out whether we can correlate phase angle to the prognosis of patients, to understand malnutrition. That is what, because after all, phase angle is body cell mass. So if the body cell mass is on the lower side, does it actually correlate with the NRS or the GLIM criteria? That is what we were looking at. And we found the phase angle Indian patients to be somewhere around 4.1 in males and 4.1 in females, and 4.2 or 4.3 in males. So anything less than that seems to be correlating towards malnourishment. So this is some new information that is coming in. Probably as time goes, we are now almost 80 patients through. So we'll probably publish the data talking about malnutrition and diagnosis of BI in this case, because at this moment malnutrition cannot be diagnosed unless you do GLIM criteria. But I think BI is a very exciting tool to actually figure out lower body cell mass. That phase angle on that is a perfect vector, I feel, for understanding body composition, I feel.
So you think that there is a direct correlation?
Yeah, that's what I am feeling, that there is seen, it looks like that, at least in the study, it looks like those patients who are having a reduced phase angle, they seem to be the ones that are malnourished, and the curve is really close to 95%. So it appears that that number may be somewhere close to 4 or 4.5, 4.1 and 4.4 in males and females. That is what the number seems to be. In fact, now at this moment, we in our ICU, whenever we are even we rent out a BI, when we do that, we are figuring out that that the phase angle, when it is on the lower side, these patients are not doing very well. But the sad part of the entire story is that even if we know it's too low, we don't have anything to improve that. So immediately nothing is there to improve it. We only do more precautionary care, and we ensure that these patients are fed well even 3 months post whatever they have come in to the ICU for.
True. Any other questions? If there are no other questions, then we can close the meeting tonight. It was indeed a very fruitful discussion, and everyone was enriched by, at least I am enriched, knowing a lot of more things than what I knew before. And I'm sure also that in the coming days, we are going to have more exciting round of exciting informations about the same technology, BIA, and its advancements, as well as on other topics. As also, Saurav has already fixed up our next meeting somewhere next week. Is it, Saurav?
Yes, 12 on 12.
Okay, and you can circulate the message, and it will be again circulated by the main ISPEN body till the time our registration is officially confirmed and the letter is in hand. And I'm very thankful to Sanjit, who has taken his time out to be present in our meeting. And I wish that his presence will immensely benefit us in the coming days as well. And also we will be happy if other city branches also join us, as in when we circulate our flyer. So of will make it that it reaches the others also, all the ISPEN members, those who want, they can join. And surely we want to take things forward from here, so that more and more people join and more people share their views, so that we can develop a very good scientific exchange of ideas and can plan more interesting research or more facilitate discussion, etc. Thank you, everyone. Good night, and we will be back again next week.
Thank you.
Thank you.
Bye bye. See you then.
Thank you.
Thank you, sir. Thank you.